Welcome, everybody. I'm Mark Peter Davis, managing partner of Interplay. I'm on a mission to help entrepreneurs advance society, and this podcast is definitively part of that effort. Today, we have a really cool conversation. I've got Alex Barrett, who's the CEO and founder of Meroka. This is a company we had the great privilege of investing in at Interplay, and they are doing really, really interesting things in the healthcare space. They are helping to give small practitioners, independent practitioners of doctors' practices, scale advantages so that they can get reasonable pricing and good operating infrastructure without having to sell to private equity and other traditional buyers that may run the practices in ways that kind of are not always in the patient interest. There's an inherent conflict with some of these larger owners between profit motive and operational quality. He's a very articulate fella, and he's got a great perspective on what's happening in the healthcare ecosystem. I think if you're at all curious about the space, if you're not sure why healthcare is expensive or not working, this may illuminate the answers to you. Enjoy. Alex, thanks for being here, man.
Of course, this is a blast.
Okay, yeah. Let's jump in. I think I want to go through a lot of the big thinking you have and missions you have around the healthcare system. Yeah. Before we step into it, though, I think it's important to kind of level set. Will you give us like a high level on Meroka?
Yeah. So Meroka is a company that I founded just about 2 years ago. And our mission is really to save the independent practice of medicine. Today in the healthcare system, if you look around, it's largely corporate run, which is just a real departure from the way it was 30 or 40 years ago in America. And we are singularly focused on trying to shift the balance of power back in favor of independence. What we do today is we've come up with a decentralized ownership model to preserve independence in medical practices, given the clip at which they're just selling out to private equity and large hospital systems. And so we allow a practice to sell their practice and get liquidity for that business while keeping its independence private through an employee ownership structure that we've created and deployed into the market. So a practice can work with Meroka. The end state is the physician owner can still get rewarded and get the liquidity that they have in that business. And the actual eventual owners of the business are the employees and the people delivering care on the ground. They're the ones that show up to work every single day. They're the ones that treat patients and design systems for patient care. And they should be the ones owning the practice, not a capitalist institution.
So you've got this, in the way that was framed, there's kind of this implicit evil empire, corporations bad. And maybe in this context, that makes sense. Can you explain what the benefit is of having individual independent practices?
You know, the life of a physician is really a crazy one. You spend a lot of time in school, like perfecting a craft, and it really is this mixture of art and science where you've got to learn about patient care, bedside manner, how to take in information, communicate, and then you go and, after probably 15 years in school accumulated, you then go and you start working in the healthcare industry. And physicians should be the one that decide how long they spend with a patient, what the care plan is for that patient, how to approve the care plan for that patient, how to design the experience that patient has from the second that they walk in the front door to the couch they sit in the lobby, to how long they wait for their service, to what referrals they need, what other practitioners they need to see, and who those people should be and to benefit that patient. And that's what independence gives doctors. When they're independent, like we have independent physicians that give all their patients their phone number that they can text in the evening. We work a lot in the obstetrics industry, and like that's critical because like symptoms happen in the night, they happen overnight. And like the power of independence is in cultivating really that unique and personal relationship that's physician driven towards that patient experience. And unfortunately, when you're an employee of a system, there's a lot of good in that. I'm not going to spend this whole conversation putting the system down necessarily, but it takes that autonomy away in the way that a physician's able to direct that experience and that care plan for the patient. And that ultimately has really negative downstream impacts on quality and experience and care and outcomes.
So what we're talking about, brass tacks, is big corporation is going to sit there and say, hey, you got to spend X number of hours. They're doing, someone in the operations team or consultant is doing some math with maybe best of intentions, but coming up with a program for what care looks like. And that might ultimately be too rigid for what needs to happen in the field.
Well, we've sort of the way that we built this system is out of a desire for scalability with, like you said, the best of intentions. The things that scalability allows you to do is make care more accessible to more people. By consolidating things into centers of excellence and academic centers and multi-specialty under one roof and all these sort of things, it allows for higher throughput. When you restrict how long somebody can spend with a patient, when you put more patients in schedules, when you optimize every inch of the building and the physician's time, what it allows is throughput. And throughput is not all bad. Throughput, as I said, results in more people getting access to care.
Right.
The thing is that we're at a moment in time right now, I think, where like we don't have to make that trade-off between throughput and scale. Like we did like 20 years ago, but like, throughput and efficiency are democratized today. Like tools are ubiquitous. Clinical decision support is in our pockets. And so that trade-off is no longer a relevant one. And so the initial intention of scale and systems is like sort of an old intention. But now it's having a tremendous downside on physician and patient experience in the system. So we should redesign that in favor of patient experience rather than in favor of throughput.
Is this a fair reframing of what you're saying? Yeah. To get scale advantages and economies of scale, the old model was aggregate the industry, consolidate the industry, whether it's through private equity or large corporations.
Yeah.
You're saying now there's another way to achieve those benefits without just stacking all of the bricks on top of each other.
That's absolutely right. And the better way should be cheaper for the healthcare system as a whole because it pushes power out to the edges and democratizes the use of technology and systems and should result in higher quality of care and accessibility.
So what is that way? So if it's not sell to a private equity firm, not sell to a big corporation, and it seems like, I don't know the industry as well as you do, but it seems like a lot of the medical practitioners are selling. And the motivation that I understand it to be is, look, they have a bargaining disadvantage with all their suppliers when they're small, right? And that kills the margin in the business. It makes it hard to operate. Mm-hmm. So they need to be part of a bigger group to get better margins, right? Mm-hmm. So play this out for me. What can someone do other than the private equity move?
For some reason, so what you're saying is very valid, which is that power comes in numbers. And this is true not just in healthcare, but in lots of other industries. And essentially like aggregating together gives you more purchasing power and allows you to, the big place that manifests in healthcare, like we could talk about every expense line item and group purchasing. None of it matters. The big way that this matters in healthcare is your reimbursement rate. And the way that the traditional consolidation of healthcare works is you assemble practices under one entity, and you call it a tax ID or a TIN. And that entity negotiates more favorable payer contracts because they have more density in a region and they control network of that specialty.
So reimbursement in this context is effectively for general business price. Yeah. It's what you get paid per procedure.
What you get paid per procedure. Yeah. And every practice gets paid a different amount for every procedure for every different payer that they work with. And that price is a negotiation based on leverage and based on what you can command for that price. What you can command for it today as a practice has nothing to do really with the quality of care that you provide or the patients that you see. It has to do with your density and size. And so where I was sort of going with your statement, which is an accurate one, which is, aren't things better in numbers? For some reason, we've confused and conflated working together with control and governance. And like, I don't necessarily think that those two things need to be in the same transaction. So it's like, it might make sense that, if you're a singular OBGYN practice, like you probably need to collaborate with members of other specialties in a region so that you have a network that matters to somebody. That is probably true. But does that mean that you need to sell to a private equity firm and relinquish all the equity in your business and relinquish all control of decision making and how the business gets run and change all your tech stack and remove your staff? Like that's so far removed from this idea of togetherness that, our model is to provide the benefit of scale without the cost of consolidation, right? So they get the benefit of working with a singular system like Meroka that allows them to still represent a node of a network and be part of a platform, but where the governance, decision-making, profit, upside, equity aggregation, all of that still lives with the people in the business, in the small business.
But that abstraction didn't exist before Meroka, candidly, right? if you wanted scale, there was one way and one way only, and that was to get acquired and get rolled up.
Yeah.
What's the scale pain point? I know it's significant. When we're talking about reimbursement rates, so the price that people get paid, percentage-wise, roughly, what's the variance if you're an independent shop who doesn't have much negotiating leverage versus a monster who does? Are you making twice as much money, 20% more? Like, what's the order of magnitude of change?
It is region dependent, specialty dependent. So it's the average reported figures nationwide are 2 to 3x, which is just like a huge order of magnitude.
So you get 2 to 3 times more money for the same activity.
If
you're part of a bigger team.
Yes. Yeah.
How does that even make sense? How is that not legislated?
So if you think about the business of being an insurance company or payer, and again, not all of them are bad, and not every practice that works under those systems are bad. But if you think about the activity, what you represent, your customers are employers mostly. And so you're an insurance company in a region, you are trying to sell health plans through employers. And those employers have networks of employees that need to go get access to care. So what you really care about, your economic function as a payer or an insurance company, is you need adequate network density, just adequate enough that whenever an employee, if one of your employer's customers in that region needs to get access to care, it's available to them.
Yeah.
And you want to pay the least amount for the adequacy of that network. That's the economic function. The easiest way for them to get that network adequacy is to work with groups that have it, not assemble large networks of small independent nodes, because that carries risk. And so they'll work with large systems, they'll work with consolidated entities. And so if you're trying to run a payer negotiation strategy, let's say as a private equity firm, what you really want to do is you want to look at a region and you want to say, okay, in this region, there are 35 obstetrics providers. If I go and acquire 15 of them, this really matters to somebody's network, right? Because now I've got 15 of the 35. And so now I can call that and I can say, your network adequacy is at risk if you don't work with me. And so the power and the leverage and the negotiation changes by nature of representing some part of that network adequacy that you can convince them is at risk. So that's how those negotiations go. If you're a singular obstetrician, you don't matter to anybody's network. And so you can call them all you want. You can tell them about your quality of care. You can submit data packages. They do all those things, right? They hire consultants to go review their contracts and their collections. And ultimately, there's just an upper limit to whether anybody cares about any of that data, because you don't represent a risk to their network. So that's just sort of an insight into how that works in practice.
In this reality, how is anyone staying an independent practitioner? Are they starting and they do it for 2-3 years and get out because it's just there's too much pricing pressure? Like, what's the motion here? How is it not all consolidated already?
The state of the market, to be quite honest, we identified this business opportunity obviously before we started the company.
Yeah.
Around the pains facing independent medical practices, how acute those pains were. We obviously did a lot of customer validation. I would say one of the biggest learnings we had in our first few months of operating is that the pains were deeper than we anticipated. And that's actually hard. Right. I've never thought of one of the hardest things of running a business is that the pain is deeper than I thought.
Yeah.
You would want that as an entrepreneur, right? But actually it's one of the hardest things we deal with, because we actually most businesses that we show up to are in survival mode already. And that presents a lot of risk. So the way that to answer your question directly, the reasons that they're still around, how can you basically survive as an independent practice today without selling? The biggest way people have done it is by selling out.
Right.
That's why 70% of physicians today are employees of a system. The ways that they can do it independently, work more. So all of the billings in a practice comes through the main couple of physicians. If those physicians are just willing to drive more production, they can make more money, which means they work incredibly long hours. And the problem with this actually is it's great that they make a little bit more money by doing that, but it actually harms their enterprise value, because the more it inserts more key person risk around one person. And you look at that business and you're like, okay, the only way they're profitable is because this person is working 80 hours a week. Can I replace them? Right. And if I replace them with somebody doing 50 hours a week, the business is not sustainable.
Every private equity person's got to know that math.
Right. So they're actually that method of making more money this year is a reduction in equity or enterprise value of their practice, which sort of sucks. The other way they can do it is ancillary services. And this is more prevalent in some specialties than others. But for example, in the obstetric space where we spend a lot of time, almost every single one I know is now trying to start a med spa or an aesthetics business. Why? I'm serving women between the ages of 25 and 45 that are going through major life-changing, moments, and aesthetics and med spas are an obvious output of those things. So that is a one way. And like for another example to that, in like, let's say the orthopedics industry is like, okay, can I become a partner in a PT, practice, or can I launch physical therapy? Can I do all of my surgeries in my own surgery facility, which is basically embarking in new business lines that are more lucrative than traditional medicine. So it's like diversifying away from traditional medical practices because those reimbursement rates are bad, and doing things that are not traditional medicine. The third way, which I think is becoming more and more prevalent right now, we're seeing it more than ever, especially in places like where we're sitting right now, which is Manhattan, which is monetize my brand as a physician. Mm-hmm. And the way that I monetize my brand is by charging cash for it.
Right.
So you want time with me, you want me to answer my phone, you want me to show up in the delivery room when you're delivering you're delivering the baby. That's all in and above what I'm being reimbursed by an insurance company. And you're going to pay either a cash service, a membership fee, a concierge license for it.
I've seen this all the time now.
Yeah. You see it hugely in Manhattan. Like this is and it's because of the sort of affluence and the density and the brand recognition of physicians that are attracted to this region. It obviously starts in places like Manhattan and Los Angeles and Chicago, and it expands out into the rest. But we're seeing this more and more, even since we started the company, be present even in rural areas and be like a real way that physicians are monetizing.
Now, doctors are famously, I don't know if it's true, but it's certainly the stereotype, bad at business, right? And so that's kind of the stereotype going into this. You've got this reimbursement rate issue that you need scale for. Are there other reasons why private practices need to kind of partner up? Is there another dimension to this, or is it really just the reimbursement rate at the beginning and end?
So maybe this is a hot take, but I hear that statement all the time and I hate it.
Good.
I hate the doctors are bad at business thing. And I actually vowed for us never to say that. There is an incredible amount of healthcare companies out there whose first statement on their website is some version of, you practice medicine and we'll take care of the rest. It undermines the knowledge, effort, and resilience of that person. Most of the practices that we work with, and these are independent practices again, these doctors have been building these practices for 20 or 30 years. They're entrepreneurs. Like these people that we talk to are entrepreneurial as hell. Like they stood up a practice, they negotiated contracts with payers, they figured out how to acquire patients, they run billboard ads, they run TV commercials, they learned how to run things like digital ads. OBGYNs today, where are their customers who are in their early or mid 20s? They're on TikTok. Like these doctors are learning how to use these new mediums. They hire people, they fire people, they manage people. That they run a business. Okay. And they know they didn't go to school to run business. And is it their the thing that they're known for? No, they're known to practice medicine. But we try to lean into the entrepreneurialism and embrace that element of their being, rather than tell them that, hey, they're bad at it, give it to us. To me, that sort of destroys the whole beauty of independent practice, where actually some of the decisions that they make on those items are what define the complexion of that business and why it's better or different than the system.
So in that context, is there a second or tertiary dimension that the physician entrepreneur gets out of partnering with someone outside of reimbursement rate negotiations that are significant to them? The other reasons they do it, other than getting liquidity?
Liquidity is valuable for the business owner. It's not valuable for the business typically. And so that is obviously a major piece of that puzzle. And it's a major piece of that puzzle because of the demographic trends. A lot of these physician business owners, and even outside of healthcare, a lot of business owners today are in their 60s. That's the average age of a business owner in America. And just by nature of that, when you have business owners of that age, there is an obvious death date to the independence of that business, even in absence of this whole healthcare system concept. If you can't solve the problem of business transition and liquidity, you actually can't save independent practice, because even if you do all the right things to help the business, there's a death date to when that person is willing to work at that practice anymore. So, I mean, that's why we leaned into this ownership transition pathway, because actually, like, while system ownership is bad, individual ownership is also bad, because it has that natural key person death date attached to it. And so that's why we tried to reimagine this like decentralized business model, which is what are actually the like thoughts about permanence and longevity of independence.
Can you explain your model so someone listening to this is thinking, okay, all right, so I get it. Selling to private equity has some downsides. There's a scenario here that is different and interesting. What is your actual approach?
We stand up an employee ownership trust. The employee ownership trust manages ownership on behalf of anybody that works in that practice. If you're involved in that practice and you get paid by that practice, whether you're a receptionist, a nurse, a physician, you get ownership and a real ownership stake in that practice. The reason this is exciting is it's permanent and it stands the test of time, because as people cycle in and out, they effectively trade the equity in that business over time. So it always stays independent. There's never a need to exit somebody by needing a liquidity event or capitalize it somehow externally. It's a permanent structure set up with longevity in mind, such that it always stays independent, and you remove that death date from the practice's timeline. So a practice working with us can stay independent while joining a system effectively.
Scale advantages, liquidity,
correct,
and more permanence to the employee.
More permanence to the employees.
Now, one of the things that you hear this, you think, okay, whenever you hear the employee ownership programs, there's always a worry that there's not as much of a market dynamic around valuation. So the liquidity moment for the owner is less certain. Maybe. How does this usually work out? Is it a better or worse deal, or about the same as doing a private equity transaction? How does it look for the founder?
Well, employee ownership deals are actually subject to a lot of legislation, but like one of the most important things is that they actually must trade at fair market value. And so like our goal is never to shortchange a physician. Like we try our best to establish fair market value with that person. And I think that that's how most acquirers, reach these conclusions. And so when we look at it on an aggregate basis, like we pay as much or more than traditional acquirers. And the reason is that like, we don't have like funds that we need to flip these businesses to return capital to. So like, not all private equity firms are bad. I want to say that again. I know some, and I have friends that run some that build great cultures inside these businesses, but they all suffer from like one fundamental problem that they can't get out of, which is the need to return capital on a timeline. Right?
To their investors.
To their investors. And the result of that is that, and maybe people are not aware of this, but like every private equity transaction has two sales. So a private equity firm goes and acquires a business, and they do that times 25, times 50, times 100. We talked about they try to build that collective scale. But that's only the first sale, right? These practices sold into the private equity firm. What the private equity firm then does is they take the portfolio of assets and they resell them at a much higher multiple than what they bought them for. And the business model of a private equity firm is something called multiples arbitrage. And my goal as a private equity firm is I want to buy a whole bunch of things for 3 or 4 or 5x, and I want to sell them for 10 or 11 or 12x. And I'm selling them for a much higher multiple than I bought them for, because I've created standardization and economies of scale in that portfolio of things. The problem with it is that second sale is so unknown, is so unpredictable, but yet it's a guarantee in the model, because it's the business model. That's what drives the returns and the earnings for the private equity firm. They don't hold dividends over time and hope to accrue value that way. They must sell the portfolio.
Yeah.
So what we tried to imagine here is like, and this is why this idea of like permanence and longevity is important, is like a real ownership model should not have to exit again to make the business model function. So what that means downstream is like, I'm actually less valuation sensitive. I'm less valuation sensitive because my business model is aligned with performance of the independent asset. It's not aligned with what multiple arbitrage I can generate over X period of time. And so I'm more flexible in being willing to pay more because I have a longer time horizon by which that asset's going to be part of my ecosystem.
I could also imagine from a doctor's perspective, knowing who your partner is, if you're going to stay involved in the business, or if you just care about the people that stay behind if you leave, is a totally different dynamic than knowing, hey, this is my partner for 3 to 5 years, and then all bets are off.
Yeah, 100%.
Right? Which could be better or could be worse after, but it's a gamble. Yeah. And it's an important gamble.
Yeah, that's right.
Taking a big step back, this has been so illuminating. If you could have a kind of a carte blanche, if you were king and you could change the system, what would you tweak in the healthcare model, very macro? The kind of the model you're building, the approach you're taking is all kind of a byproduct of the framing of the current machine.
Yeah.
How would you change the machine?
There is a huge disconnect in money flow between the people paying for care and the people delivering care. So this is something that's not shed light on often enough. But for every dollar that you pay in your health plan, like about 20 cents of it or something ends up in the pockets of the people that are actually doing the healthcare work. And the other 80 cents disappear somewhere in the intermediary, right? And the biggest way to effectuate change in the healthcare system is to have a closer connection between the people paying and the people delivering. Because those are really the only two constituents here that matter. We are starting to see evidence of this right now, and I'll sort of explain how this evolves, but like health plan cost is rising dramatically right now, above inflation for employers. We're seeing a lot of employers move towards self-funded plans, direct plans, thinking about like ICHRA plans, all these sorts of ways that employers can take more control over the healthcare purchasing decision, mostly because they can't afford it, especially smaller employers. That burden then gets pushed down further on patients, where you see high deductible plans rising like crazy. And what all this means, like macro over time, is, and where the system needs to go is, the patient needs to be the consumer of healthcare, of the healthcare purchasing decision. And when the patient is the consumer, that's what drives competitiveness on the provider side, and that's what drives more,
Then there's like a real market.
Then there's a real market.
Right.
The reason there's no real market is when employers make blind decisions about off-the-shelf health plans that then patients are forced to use, and everybody sort of just accepts it because but we are seeing the first innings, and it's really a 2026 thing, but we are seeing the first innings of what patient as consumer means. And I think that that's the biggest trend forward. And I think that that's probably the biggest trend in how independence can benefit that. Because when patients become consumers, the expectation is that they'll invest in the relationship with the physician more than with the person rather than the place.
If you could start it all over, the whole system, everything's wiped off the map, you're the king. It's just starting from scratch. Would you move more towards a system where employers don't pay for insurance, employees receive that money, and then make their own purchasing decisions? Is that the implication of what you're saying?
That's right. Yeah.
So the employer insurance provider relationship, this like roundabout,
exactly,
is where you kind of get this misalignment of incentives.
Exactly. Yeah.
Okay. Fascinating.
Yeah.
Thank you for being on this podcast.
Of course, it's a lot of fun. It's great to chat with you. Yeah. Super happy to have you guys involved in the company as well.
Thank you. Thank you for having us. Huge thank you to Alex for being on today. Again, we're super honored to be part of his journey. He's a terrific founder, and it's inspiring to be part of a mission like this. So hope you enjoyed it. And if there are ways we can be helpful at Interplay, just reach out.